the technology might have some gaps, might have some, gray areas. So we need to be careful about the implementation there. And, we can see a lot of potential in this, but again, we have to be very cautious on how to implement it and how to use it, keeping the patient at the center. So that's the message. And the second idea here is that, AI, it's an assistant it's a co-pilot. It's not going to replace the doctors. It should never replace the doctors, because it's philosophically wrong that a machine, replaces a human being when interacting with another human being. So really, there's a philosophical question in the background here. So and also obviously a practical question in terms of liability and governance of medical errors. So truly, we are putting the human being at the center of this, both from the patient side and from the healthcare provider side. AI is a great tool. We love it. We love to study it and to implement it. But we really want to have a governance on this technology when we're talking about patients. So that's really the core idea, Palma.
So Sharon, as a surgeon scientist who's very active in researching this product and is contributing to the acceleration of its use in our field, what is your perspective of what Omar just said?
I cannot agree with Omar more. And I'm so glad that Palma and Linda connected us on this show, because I didn't get a chance to find you. I didn't get a chance to find you in Europe, in Dubai. So
I just help it out here,
Just have to come
we
here.
clearly have to find ways to work with each other. I think like AI, and I kind of say this in my other talks and other speeches, is that AI is not new, right? It's just new to medical use, medical utility. I remind people your stock market projections, your utilization of like Amazon purchasing tools. The military has been trying to find autonomous weapons and autonomous weapon sort of developments for years now. We just haven't really used this technology focusing on patients. And where we get lost, I think, as physicians, is we kind of see this new thing come up. We're already overwhelmed with how much clinical work we have to do. We kind of let someone else take the head, and suddenly we're left behind. And so I think like there's different ways as physicians and physician scientists, as surgeons, as anesthesiologists, to contribute to this. We all have a role to make sure that AI is done responsibly and that it's center focused towards our patients for medical innovation, medical care, medical safety. And one of the things that I remind people as I speak to, let's say, surgery groups is we're not asking everyone to become coders and start like, building algorithm labs and things like that. But we all have different ways that we can take part as we bring AI to our patients. And I agree with Omar that technology has a weird way of running away from us. As physicians, again, we're so focused on the patient-only related things. And then we rely on industry or rely on someone else, rely on the engineers and the tech people to show us how to use something. But what they are missing is that patient component. We know that the best, and no one's ever going to replace us as the experts in the patient care and the specialty that we have been trained in. So I think if we can always remind ourselves that we have to be an active participant, I think AI can be a great thing that can efficientize care, delivery of care, help look at disparities. Obviously in my lab, we are looking at disease prediction models. Right, we're looking at ways that we can project how the behavior of aneurysm will react to, let's say, this factor, that variable. We can use it to predict outcomes or based on therapy. That's the missing part from just the tech and industry-based stuff. But I think physicians are just so overwhelmed by this AI coming at them so fast that I'm worried that they will just stand back and let all the industry and tech people just take the lead. And that just cannot be. That just can't be. So I'm so glad that Omar has started this, giving us a voice in all this. And if we can just all come together, we can build it for us.
I also cannot agree more with you, Sharon. Like, it's a wave. It's a big wave of progress, right? Or development. So I'm gonna say this: there's a difference between progress and development, which we should be aware of. So development is technology, right? It's the evolution of technology, and it's something that it's going ahead very fast. But we as physicians, clinicians, we're not keeping up with it. Not the policymakers, nor patients. So it's a technology that's evolving so fast. it's a rapid development. But for that to be called progress, really we have to make it intertwined with the ethics of it, right? So really have to bring back the ethics at the center of the conversation, because development met with ethics and human-centered care, we can call that progress. Whereas, as you said, if we leave that in the hands of the CEO companies of some tech industries, we don't really know where this is going. So we might create the risk of having this technology driven more by efficiency of the system, or possibly by profit, and not by patient-centered care. So that's the risk, which we want to avoid. And also, as I was talking to you before, there is a question mark about data governance and data protection. So if we put patients' data into the systems, we don't really know where this data, patient data, is going to be elaborated, where it's going to be interpreted. So maybe it is used to be, maybe it can be used to, train models. We don't really know where the patient's data is stored. So there's a lot of question marks also in terms of patient privacy. So there's many gray areas in this domain, and we really have to be careful. Again, it's a beautiful technology, and it's, as I said, it's a wave that it's coming. And so we're either going to be crushed by it, or we're gonna have to kind of surf it. So, but as you mentioned there, literacy is very important. So we have to be AI literate. So we cannot lag behind. We cannot not think that we should not learn about this. Again, we don't have to be coders or developers or whatnot, but we need to at least know how this technology is used, and we need to know the gaps of it, the biases, the issues with it, so we can interpret it correctly.
Yeah, I agree.
In an ideal world, speaking of efficiency, I mean, don't you think AI could really help? I mean, part of the problem with burnout with physicians in all fields is like all the paperwork, the documentation needed, everything like that. I mean, we went into this to help patients and to have that personal interaction and that relationship. And then what boggles us down is like, okay, now with one patient, we got to document, there's like 15, 20 minutes of doing all this other stuff. I mean, do you think AI would be able to help with that? Because I've already heard apps that can listen to you while you're in clinic and do your clinic note for you. And bill for, like all, where you don't even have to worry about it. But then in my mind, I'm like, well, who's controlling that? And is that even HIPAA? Like, where is it going? It's on your phone. Is somebody listening? I mean, because I talk about something and Instagram, next thing you know, has ads on what I'm talking about. So can you go more into detail of what you were talking about, like privacy issues, and how are hospitals going to deal with that as well?
Exactly. No, that's a great question, because, as you said, efficiency will be impacted massively by this technology. Doctors are drowning in bureaucracy, layers and layers of bureaucracy. I'm sure that's happening in the US as well. Here in Europe is dramatic. Like, we are constantly writing down notes, making sure the medical legal part is covered. So there's a lot of paperwork going on, and there's a lot of notes taking. So of course, AI will streamline that, will give us back the time that we need to spend with the patients, and that's really important. At the same time, we have to be careful on how this can create mistakes. For example, the wrong interpretation of a sentence that we might say, that can be then transcribed incorrectly in the notes, and that can generate wrong summaries or wrong billing codes, or some issues of this. So really what we need to do as clinicians, like for anything else when it concerns AI, we really have to double check what the AI is doing. We really have to be able to audit the process, and to as doctors, sign it off, right? So the doctors need to be able to sign off the decisions or the assumptions of AI. And again, those apps, as you said, you mentioned, we put this patient's data in there, those transcriptions that have a serious medical legal implication. But we don't really know where this data is being processed, where it's being stored. The companies, sometimes they put a big disclaimer saying that they're following the GDPR rules, but really, can we really, scrutinize this? And that's a big question mark. So Europe is leading on this. They just published recently the EU AI Act, where it's a risk assessment of the AI technologies that are, brought up in certain sectors of the economy. But really, there's a lack of standardization across the globe in this domain. So there's no real international framework of implementation and of governance of this. So really, you're putting your patient's data in these apps. We don't really know where this data is going and how it's processed. Again, these apps are fantastic, they're phenomenal, but really we have to be careful about our patients' data.
So just to echo back on what Omar is saying, I agree with everything he's saying. And whenever this topic comes up about becoming more efficient, let's say getting through clinic faster, running programs through how you're going to, find the best fitting graft, trying to get notes done, I am always like a little bit of a Debbie Downer when it comes to this, because I think it's very dangerous sometimes when you have patient data and HIPAA data involved and you have imperfect technology. A lot of people in different forums ask me about large language models, right? ChatGPT, generative AI, in terms of how they can actually make their clinics faster. Just like an example you gave, an app that actually listens to your clinic and generates notes and things like that. And one of the things that I caution is I think these things have great potential. And I think at some point we need a way to beta test it. But at the moment, there isn't really a lot of transparency, just as Omar is saying. Data is like the new gold mine, right? We don't know where it is. We don't know how it's stored, but we do know data when it transmits out is forever. So we have to be realistic that as they are asking for data, they're also using it to generate better, models of whatever app they're doing, but we don't really know how they're actually containing the security and the privacy of it.
Yeah, and I mean, I'm assuming big hospital systems. I mean, I've not used it, but I've heard some of my private physician friends have, and But big hospital systems, I can't imagine. I mean, to log on to one app for Methodist takes you like 10 minutes because you got to put it, authenticator, I mean, all this stuff. So I can't imagine that working well with a big hospital system.
Yeah. So, I mean, just to, encapsulate the point is that imperfect tech, there is no real way to validate it. Large language models are extremely complex. There's semantic error, there's diction error, and it's hard, especially when you have a medical legal thing involved. I've had people argue with me, well, you don't really know how a Tesla works, right? But you still trust a Tesla to get you from point A to point B. And I want to laugh at their example, but I get it because that's actually how they're thinking about it. In this case, it's a totally different, I think, severity algorithm. You have a patient risk benefit ratio, your license, your practice involved. And I think that is a whole totally different stringent level of oversight. A lot of AI stuff in the US, Omar, please, you jumped in on the Europe stuff. A lot of it's reactionary. All the stuff with the FDA, a lot of it of the government oversight is because something bad happened or something's about to happen or they caught something and now suddenly they're setting standards for XYZ, things like that, right? A lot of it's reactionary, which means it's really not that much of an oversight in the end because they're actually just reacting to the new tech that is coming out. And so I think, go ahead.
No, sorry. And no, you're absolutely right. I mean, but there's no other way to deal with this technology because it's evolving so rapidly for everybody that even policymakers are not able to keep up with it. Everything is reactionary. In Europe as well, even though Europe is really up there in terms of data protection, but it's still like this technology is so fast that policymakers are not keeping up with it, and that's why really we started this society, because the idea behind it is to advocate for international standards of implementation of this technology in healthcare. So really, nobody was talking about it. There's different AI companies left and right in different continents, different regulations across different continents. In some continents, there is no regulation whatsoever. So in hospitals, you have people using ChatGPT. So really, there is a different standard of care internationally, and that's what we saw, and that's why we're advocating for a standardization of the implementation of this technology and the regulation of it on the international stage.
So this really seems like maybe the bad and the ugly, but maybe we could talk about the good, right? So, the reality is that ChatGPT could be really helpful. Like if you're writing a thank you letter for like a wedding present or a Christmas card,
Right.
gift or something, boy, it saves you a lot of time. But, I think a lot of primary care physicians are drowning in work. I mean, they're looking for ways, and I saw a webinar online about a primary care doctor abroad talking with, like, I think it might have been Elsevier, and they're just saying we need help. We're drowning in, and we can't coordinate care for all these patients. It's just too complicated. We don't have the bandwidth where we need help, and they're going to turn to AI. You can warn them all you want, but they're just trying to survive another day, is the way I look at it.
Yeah. No, I think AI, so there's a lot of written works right now, at least in US publication as well, not only just on the patient facing side of things, but efficientizing processes and hospital, automating certain types of things, let's say from triage in ED to, the next steps and things like that. There's a lot of work on that in the ICU side of things, on the ED side of things. So I think there is a huge potential to actually help on the primary care side of things. On the positive side, because I mean, there's so much good that AI can do, is that it actually will probably obviate a lot of the generic apple pie sort of screening type based things that I think to some degree we can probably hand it off a little bit if the algorithm was right and if we have the right people sort of validating its results, right? Kind of quality spot checking how things are going. It's never going to replace primary care, and I don't think that's what they're asking either, right? They're just really trying to find a way that maybe they can offset 40% of just your generic routine automated sort of upkeep maybe to AI. I don't think that's a bad idea. My worry has always been that people rush their way into doing this and rush their way and then, kind of becoming too relaxed, thinking that AI is going to be the silver bullet that's going to take care of all of that. Do I have a giant answer algorithm building in my lab to solve this? I actually don't. I have seen models, though, where they deploy AI-based screenings on, let's say, like a low access location, a low access population, where it's very hard to get them to the hospital, get them to their providers. And that seems to have some like data that shows that it actually is not harmful, right? We have yet to see whether it's truly successful in bringing low access demographics, to the care that they need. But at the very least right now, I haven't seen any data to say that AI is outrightly missing giant red flags of things. So I think like there is room. Omar, please jump in.
Absolutely. No,
Yeah,
look, Palma, I am all for this technology. I mean, I love it. We are fascinated by it, and I truly believe there is great potential in it. I mean, I'm not against it by any stretch of the imagination. I'm actually promoting it. But the idea behind this is really so okay, at some point in time, it will be unethical not to use it, right? So it's just like when I was training in anesthesia at the beginning, we were inserting central lines blindly without the use of any, ultrasound machine. But then ultrasound machine came along, and we had this technology. And now if you insert a central line, without the ultrasound, then you're liable medical legally if you make a mistake, right? So it's unethical not to use a technology that's available to you. And down the line, I see in the next 5, 10 years, it will be sophisticated to a degree where you cannot say that you should not use it. So we will have to use it. And it's great for patient care. It's great for streamlining processes. It's great for getting rid of this paperwork weight that we all have, right? But the idea here really is to be careful on how to implement it and have a framework of implementation, really a guidance where we are using it in the right way. We are literate about it. We know the possible biases behind it. So really, we know how to use this. Just the way you learn how to use an ultrasound machine, right? You're gonna have to learn how to use AI. So really, as Sharon was saying, you can't jump on a technology that is not perfect. right? So we need to perfect the technology, and then we have to learn about it. We have to learn about the biases or about the algorithmical issues behind it, and then we can safely use it. So that's what we're saying. We're saying that we need to learn about it, and that we need to implement some implementation standards around it. Just another addition there. Another interesting way to use this technology is to be able to write diplomatic letters to your colleagues or to different departments. I don't know if you.
It saves a lot of time. You can drop
Yeah,
this
Yeah.
into
you
chat
can. Sometimes,
GPT,
sometimes I am
drop it
very
in, and there's
angry
a
with
letter
some.
for you. It was better than
Sometimes I
I could
might be
ever
angry
make.
with some colleague. You just pass it through and you just say, "Oh, can you make this a bit more diplomatic?" So there's a lot of benefits, of course, Palma, but yeah, we have to just be careful. And as doctors, as clinicians, we have to be in charge of this technology.
Like one of the things that I think primary care would be interested in, and I'm speaking purely from like a vascular surgery sort of focus side, is we have basically computer vision based mobile techs now. So they can assess wounds and help people determine what it's venous insufficiency side versus arterial insufficiency side and things like that. So see thermogenic sort of like visual based AI algorithms where it senses heat and temperature and whatever stuff like that. I mean, like in the PMD world, and I guess the primary care world, I can see that type of technology augmenting their efficiency, right? So they're not going to completely be like, okay, well, you don't have to come see me for 6 months. This computer is going to take care of your wound, but at least it guides them quickly or quicker into getting those patients the care they need. So there is some work. It's just, again, to echo a little bit of what me and Omar's been saying this whole time, is the sense I get when these things roll out or AI is talked about, these physicians or a lot of us just throw our hands up and be like, oh my gosh, it's too much. Someone just do it for us or teach us how to do it. And what I think we're all a little worried about is when we throw our hands up and kind of divorce ourselves from being responsible users, right? And AI is weird because when I speak AI, people look at me like I'm speaking Klingon. It's literally a whole different language. And there is a fear factor in there. We just can't be like that. We just have to be super involved because this thing will run so fast. There is so much money, so much industry involved. And it's not going to be transparent, right? Everyone has intellectual property issues related to this, whether you're on the academic side, whether you're on the industry side. So no one's ever going to be like, okay, let me tell you exactly what it does. And that's the weird thing about AI that I think is a little bit different from, let's say, all the other previous innovations that we have developed as a medical community, is that this is purely a business-faced innovation from the get-go. We're now just using that for medical. So the thought and the, I guess, approach to it, we can't treat it like how in the old days, how pharmaceuticals and things like that happened. Right. There's a huge business component that was previously already at the, racing to the front lines before we even thought about translating this to patient care. And so they're still thinking that way,
So the Society for Vascular Surgery took the lead on this, right? They put a committee together, the New Innovation Technology Committee, and I think, Sharon, you're on that committee, and your group published a nice paper recently in JVS about the application of AI in vascular care. I don't know if you want to comment a little bit about the initiative there.
Yeah. So, I'm actually not part of the committee. I just somehow end up super involved in all the works that they do. But I think the tech committee is not specifically only on AI. It's really on all the emerging types of tech. Robotics was previously featured. AI has been kind of the new brainchild on this one. And we really wanted to highlight not only AI in medical world, but, to be more specific towards the vascular surgery audience. The most recent paper was really looking to see how AI can benefit patients on the process level, on the diagnosis level, but we also hit certain things like on the economic and, financial stream level in terms of the different degrees of middle type of work that can be cut out, right? Basically improving processes, improving the rate of delivery of care. And it was a really great way to kind of introduce broad concepts. Like some of these topics are clearly things that people study heavily on and, will prioritize in different ways. in different ways, we have tried to bring this to all of the medical community. Probably a little bit of what Omar has been wanting to do, but we've done it in a publishing sort of way. So seminars of vascular surgery had an issue that we curated for AI. We're doing this now for JBS-CIT as well, to be on the more technical and basic science side. And we're going to have a specific issue in Journal of Clinical Medicine too, to broaden the delivery of some of these concepts and use examples outside of surgery. So there's different ways that we're trying to hit different target audiences. And part of it is also just familiarizing people to terminology, right? AI talk is weird. It sounds like we're tech people. We're kind of like the bros of industry. And it must be scary just how endovascular stuff first came out. But AI is here. AI is going to stay. AI is taking over the world, apparently. So part of it is also in a way, de-escalating the fear of the terms. Like, people need to just start reading that vocabulary and being okay when they hear it and not have an instinctive reaction of just avoiding it. Because I think that's how a lot of people feel. It's a lot. It's overwhelming. And if we can at least start familiarizing terms, that's already one step forward. And then we'll start, dripping in concepts and making sure that's become part of normal talk, normal vocabulary.
So do you think it'll be, for example, a patient case-based scenarios, right? So I have a patient who has had PED, smoker, all these things, bad heart, all this stuff, and numerous bypass stents. I mean, like by 5 different people, and then they come to my office. I'm like, "Hi, you're a trained
Of course,
nurse."
yes,
Of course,
yes.
like, just going to be last.
Of course,
okay?
yes.
Only like hard cases. Thank you so much. And so, part of it is like, where do you really draw the line? I mean, where do you say you don't get that fourth bypass? I mean, you're done. And can AI, and emotionally, it's hard as a physician. You want to do everything you can, but there's a point of no return. Okay, I mean, if you don't have adequate runoff, or you don't have this and that, and I think lower extremity stuff, you just say get an amputation. But I mean, I think there's a point at which maybe AI can help us make a more concrete decision about the futility or the practicality of offering that additional intervention for that patient.
So I think that's such a good example, because this melds the concepts of AI to what we call precision medicine to some degree, right? AI was never meant to replace our judgment, but what AI does is it can take infinite numbers of variables that seemingly look like non-linear related things and create connections and offer different, maybe risk-benefit ratios in your particular patient's case. How I have used some AI tools when I speak to patients is not really like, look at the algorithm here and tell them, but I give them my assessment. I actually give them my professional opinion. And then I use AI and its, prognostic indicators to also then add an additional piece of evidence to them, because it adds to the general conversation to say, I think this, everything that you experience and your evidence says this. And I also ran it through my AI algorithm, model. And AI also is on the same page to agree that you are not a good candidate for XYZ. Your frailty index leads to this possible outcome. And I think they hear it better that way. Some of the patients come to me and say extraordinary things. They think I'm building Skynet in my lab.
Or Terminator.
Right? Terminator. Or I'm going to implant a nano robot or something to spy on them as they, whatever. My veterans think all sorts of, they watch a lot of movies. So yeah. But if I just kind of talk to them like that, I feel like they accept it better. There's just a lot of fear from their side too, thinking that they're going to get something implanted in them and I'm going to control their brain waves. I've heard all sorts of crazy things. I'm talking about their leg. They're talking about their brain waves to me. So there's all sorts of ideas. Probably from the Terminator movie.
Such a great point. Such a great point you're making, Sharon, there about having AI to help you giving a rationale to the patients when you're talking about difficult decisions, right? So and I think Palma, really did. I would turn back the argument, saying that really is the human being that really is at the center of the difficult decision, right? So, when you have a point of no return, or, when you have to make a decision of not operating, really, this is where the human being plays a principal role. The empathetic conversation that you might have with your patient. I was in intensive care for several years. I had to give some bad news to family members often, right? So really, if when you see a patient who's in ICU, and doctors who are listening to this and who are working in ICU, they will understand that there's a point of no return where you can really feel it, that the patient, the systems are failing, and it's surrendering, the body's surrendering to it, right? So that's the point where you're going to have to go to the family and have a conversation. And that's something that the human being can do very well. I know that in the future, the natural language of AI will have an empathetic touch, and we will have a natural human-like conversation with family members or patients. But really, when you have to have these difficult conversations about a decision to not proceed with the surgery, or decision for end of life, really you need to have the capacity to sit down and look the patients or the family members into the eyes, and talk to them on a humane level, and perhaps listen to them because they want to express their feelings, right? So I see it difficult for these kind of interactions to happen between humans and the machine. Even though in the future it would be again very empathetic, perhaps very natural, but it still is a machine. And I think family members or patients, when they want to hear a difficult conversation, they want to hear it from another human.
Can you
So again, really is the AI will give you the backup of your decision, right? So you might, give a strong opinion about certain known treatments, or difficult choices, and then you come with your evidence because it's backed up by all this fascinating technology that has gone through all the literature and all the evidence, and it's backing up my decision. So that will give you a layer of reassurance as well as clinician.
Yeah, we're talking about language of talking about AI. Because I mean, I don't know much about it, but can you explain when you talk about algorithmic bias? Like, how does that play a role?
Yeah.
So
So I think
yeah, go ahead, Sharon.
please go.
Go ahead. No, please go ahead.
We'll do this together because we think about bias, and we think about the generic kind of social bias, and this bias in medicine. Algorithmic bias is related to, let's say, poor data sets or biased data sets, or something that we call data drift and overfit, right? Again, sounds like Klingon that just came out of my mouth, and I can imagine the audience kind of just having just deer in the headlights type thing. But when we talk about bias in AI, it's a much more technical version of bias than just, let's say, cognitive or social bias. It's actual algorithm problems where the algorithm and its data is not suited for, let's say, generalizability. So for a case in point, your data set is too small, and the model is designed to optimize its performance based on this model set, right? And then the model keeps learning within that tiny data set for this one patient population. And then you suddenly try to take this model and be like, well, I've solved this giant problem, and I'm now going to use it on this other population. And then suddenly it is like junk, or it spits out things that are completely crazy. Sometimes it is obvious as that because the model itself did not have the large volume of data. It did not have the actual ability to learn outside of its internal bias. And data, a lot of times, is dirty. And we, as clinicians, we're so used to clinical data. We're so used to registry data. But registry data, which a lot of people are writing about using ML models right now, is process data. So I give a specific talk about this, and Omar probably does as well, looking at raw data, process data, synthetic data, because all that plays into how accurate your model is. So registry data has been compartmentalized, has been segmented, has been reworked into different frameworks by, let's say, someone else the data manager, right, the data inserter. Trying to use ML algorithms, the only thing that it's going to tell you is to validate that the registry works for what the registry is designed for. it really cannot prognosticate the pathology that the registry was trying to gather data for, right? So that is a form of data bias because it's process data. So algorithm bias and algorithm fairness really is a subspecialty field that looks at every one of these things. There is bias within the data set using the registry as an example. There's bias in the algorithm. There's bias in the validation model, like the testing validation model of the algorithm as it moves forward, because to increase the performance of the algorithm, it's going to keep trying to negate its own internal errors. And if you use the same data again and again and again, that profession is only designed for that one data set, right? So there's an overfit error. So that's how, at least I tried to explain this, which probably all sounded like Klingon again, but this is where it gets really shady, right? Yeah, when you look at these apps, like what does that mean? How can an app be so universal that it can use all sorts of stuff? And if you think of it that way, it doesn't quite. But go, Omar, please go ahead.
No, but that's correct. I mean, the algorithms are only as good as the data that are used to train them, right? So that's the bottom line here. So if you're using incorrect data or biased data or data that is only capturing a certain portion of the population, then when you're using that algorithm, the biases will even will expand even further, right? So so let's say you're training the data on a specific set of patients, maybe let's say male patients, right? So it does not translate necessarily to female patients down the line. So that's just a raw example, right? So but just to give you the image of it. So if you have a specific set of data and you're going to train your algorithm on that, the outcome will be reflecting that specific data, and you cannot apply that to the general population. That's the issue. And then as Sharon was mentioning, there is the bias of the validation process of the data as well. And then you can consider also a type of bias that comes from the company itself. Perhaps we don't know. There's a profit behind it. There is some input from pharmaceutical insurance. We don't know. So so there's so many variables and components that we need to be cautious and we need to be aware of. And that's where AI needs to be transparent. And also, like when AI makes assumptions or take decisions or give you an outcome, there has to be a way for us to see how the answer was processed, right? How the outcome was processed, how the answer was given to us. So let's say you are a clinician, you're asking AI a question about a specific type of diagnosis or whatever, and the AI will give you an answer. You have to be able to review the process of the AI algorithm that has led to that conclusion. Otherwise, you're just blind to the process, and that's another type of bias. So really, the interpretability of it's important. So like in general, we as clinicians are going to use this tool. We have to be literate about this, and we have to know what algorithmic bias means. We have to learn about these topics, about the black box problem, and all sorts of AI issues. So what we advocate here really is for the doctors at all levels, starting from medical school. We really should start considering, teaching these topics to undergrads. So that at least when they're becoming the future doctors that we're gonna, look after us, they'll know what they're dealing with in terms of this technology.
Yeah. So, I completely agree with Omar. And just as another example that we don't think about in terms of bias, because we just talked on a very technical level, right? Data and this and that is, let's just say like programs and apps. And I'm not pinpointing a specific app or a specific company, but if you have programs that hospitals have to buy for several thousand, maybe $1 million to actually install and implement, you're already cherry picking and getting places that have the monetary, the infrastructure to do that, right? And then you build the validation and the accuracy and refine your model based off the patient data off of that hospital. Then you're basically just generating a high income, high resource population. It's very hard for me to accept that all the safety net hospitals, the low socioeconomic, the food desert, and 80 deprived locations and those community hospitals can benefit from that type of algorithm. So even just on the industry point, if you're looking at, let's say, we have many different identification, right? We have ones that identify aneurysms now on a very binary level. We have ones that identify PEs, right? We have those are commercially available. Those places aren't going to like your safety net county hospitals who, maybe strapped for cash or maybe really serving the indigent, low resource, like a difficult to access population. They're not there. They're going to be in your tertiary level, like high resource, academic, maybe high powered, like community hospital, those type of places. And I get it. Like you kind of need to go where the gold mine is, right? Data is the new gold mine. They need data. So they're there to help you, but they're also there to get your data so they can use your data to refine and actually improve their model accuracy. So when I see that, I use that as an example too. We don't think of it that way, right? This is really here to help. They want to make patient diagnosis better and faster. But I think about where those apps and those programs are going. And that in itself is going to be a form of bias. I don't know if you guys have better ways.
No, you're totally right, because like the hospital in Houston, they are, they've already purchased an app to look at lung cancer screenings, right? And so it goes through, obviously there's a human person who's like checking to make sure that that is truly correct, like what they're seeing, but that ultimately that patient gets a phone call to come in to get checked out, which might mean a bronch, a biopsy, like different procedures. And that patient is going to have insurance, for all these procedures. And then my other thing was, I was thinking, well, it's, a lot of these screenings, they're looking at prior CT scans, but what if you never saw a doctor, you never had a CT scan, then like you would be the missed patient, how do we know we're not catching those patients that never see a doctor and are, on an island? So it's, it's definitely geared towards more, economically, blessed places, I would say, that have the money to purchase it.
Right. The false negatives in this context, right? You're talking about lung cancer screening. I've used the PE and the aneurysm example. The false negatives scare me a little bit, right? Because then you're counting on the original manpower of the radiologist who's dictating it out to catch the false negatives. The company's actually never going to know. It's not like my radiologist is going to call me like, hey, blah, blah, blah company, by the way, you missed this one on,
Right.
So the company never actually knows that population. Now, I try to ask this question of the companies. No one's ever given me a straight answer. And I don't think they ever will, unless I sign like 1 billion NDAs or something like that. So I don't see myself getting an answer to this. But I think about that. And at least from hospital guidelines, the final say in the medical legal liability is not on any of these sort of apps and companies that may or may not generate a report. It's literally the final report from the dictating radiologist that must document, whatever level 4 abnormality, and then generate the referral back to either the vascular surgeon or the primary care doctor to follow up on that pathology, right? At the end of the day, these companies, as far as I know now, carry no true liability. So they can have a false negative. The radiologist missed it. You never got called on like the, contained rupture, contained rupture. That liability has nothing to do with the company. That's all on us.
But the treating physician must also have some liability there. So I order a study. It's my responsibility to follow up on that study. And how many times do you read a CT scan and you say, well, I don't agree with the radiologist, or I read a vascular lab study and I'm like, I don't agree with that. They call them when they dictate that there's a vertebral artery aneurysm when you know it's a subclavian artery aneurysm. And you're like, there's a big difference here. Could you fix that, by the way? And they're like, okay. I mean, and I'm the person that's recommending to the patient what to have done. So, I mean, I feel like we also carry some burden there as well.
So like this is where I think the large language models get really interesting, right? How many times have we read a CTA report, let's say on the aneurysm, where they're like flagging like everyone basically calling a code because they annotated the length compared to like AP or
they make it the width. Yes.
Right.
Make it first. They put it first instead of last.
Right.
All the time.
And then Right. And then you have, like, say, a non-surgeon or someone who's completely unfamiliar or whatever, now sending like 500 people to the ED, calling you stat. There's like an epidemic. This is a very real thing in the VA where people are constantly sent to the ED at 9 p.m.
Yeah. Oh, like life flighting like the 89-year-old grandma from like some small town because she came for surveillance of her cancer, and they read this, and she gets to ICU and she's mad because she's like hasn't been able to eat for 12 hours. That's happened to me before, and I'm like, you are okay. It's not as big as they think, and I'm very sorry. She goes, I thought I was going to die on the helicopter. I had to close my eyes, you know. But well, we have a few
Let me
minutes.
ask you a question there about liability. Like, so let me just give you this scenario. Let's say the machine sees a nodule on the CT, right? CT thorax, whatever, and the doctors disagree, right? But then the machine said it, and we know that it's more accurate. So we go ahead, we do a biopsy of the lungs, and then you have a complication there, right?
Yeah.
But there was nothing. It was just, a mistake or a blip of the machine. So in this scenario, like, who is liable here? Is it the doctor who's liable for having, followed the direction of the machine and then ended up with a complication? Or is it the company who's... So there's a big gray area there in terms of medical legal liability revolving around AI. And really, we need to clarify all these scenarios going forward. And it's not an easy task. You see, it's not an easy task. And that's what we're facing now, and like solicitors or like, law firms are getting ready, to discuss these topics because really they see a huge gray area where, there's a lot of work to be done. But from our side, we are not discussing this, as doctors, as clinicians, we're still not having this conversation, right? So it's really important to be literate about this and to start asking ourselves some questions here, in the future, like in 10, 20 years time, who is liable for what?
Yeah.
We have a few minutes left of the show. But any last minute comments? So I am less scared of AI. We are always held liable, it sounds like, for now, until we do something about it. And I'm definitely more informed.
In the United States, at least, Omar, the clinician is liable. And it's not going to matter whether the machine literally knocked down the door of my office and assisted on something. At the end of the day, the final indication for procedure, diagnosis, and documentation is on the physician. In your case and example, a falsely identified nodule ended up going a procedure and then ended up with a complication, let's take a pneumothorax or, whatever. Pneumothorax, like, let's make it really, dramatic. At the end of the day, that is going to fall on the physician, right? Not just the proceduralist, probably the physician that ordered that referral. Even
that's absolutely true, Sharon. Absolutely, I agree with you. But then you end up in a situation where the doctors don't really know when to trust AI. You see,
like, I was talking to the PE company, which will remain nameless, that supposedly is able to predict and have an early diagnosis of PE. Their entire shtick at this one conference I was at was them saying, like, well, the earlier diagnosis than normal allowed us to activate the PERT team. And then all these people were more involved faster, which means patients got, saved faster and therefore had improved, ability to stay alive. Right. That was their entire thing. So when it's positive, I feel like they take the credit. But when there is, like, let's say the false negative P, because I don't know how many people they have missed because no one's running around looking at the false negatives and the patient never ends up with an autopsy and gets basically said that he has a coronary or something. We don't know that. I have no idea what that is. But I can bet you money that when there is a missed PE and people do find out about it, no one's going to be like, oh, the company, they didn't pick it up. So the PERT team wasn't activated, 20 seconds earlier than it was. They're not going to say that. They're going to blame the initial trauma, like whatever person that was, misdiagnose. So they're very quick to take credit.
Take the credit.
Yeah.
Yeah.
I just
Yeah.
want to thank you, Sharon, for enlightening us and all your research, and really best of luck with the Klingon term. I'm just going to get that Klingon dictionary translated, and
Yeah. Rah, 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 rah. Yeah.
and then I'm going to watch Terminator. No.
Right.
So it's got to be on Netflix. And Omar, good luck with that whole global unionization
You
of
have a
AI
lot of work,
mentality
yes.
across the world. We can't agree on anything from continent to continent, but we're going to maybe come together for AI. I'm going
So-
to join your society, and I'm going to ride the wave with you. And keep me up.
Thank you.
Palma, should we reunite in Dubai or something? Should we?
Yeah, we better
100%.
go.
Yeah.
Omar,
So,
how
look,
would
I
love
mean,
it if you were there.
just I'm not here to advertise it, but like just to give you what we're doing, we are planning to have a symposium every year, right? And we're planning to do that in Dubai, where we're just gonna have a conversation and get doctors, but also developers, and have like a networking event with developers and companies and doctors, just to have a conversation around ethicists, experts in AI and ethics, have a conversation about all this. And the idea is to have it every year, so we'll keep you up to date.
That
Let us
sounds
know
I
when
have
you
to-
check the website too, right? You have a
Yeah.
website?
Yeah.
Yeah, isma.org, isma.org.
Ismy.org. Everybody should check it out. Stay caught up.
Yeah, it's just started, so it's not really full of content, but we're getting there. We're
We're
all
just
busy
trying to help you
doctors.
along here, Omar.
We're
We
all busy
believe in you.
doctors, but we're getting there, and we have committees. We have we're planning to start a scientific journal at some point, an index journal
Okay,
for
yeah.
research. Yeah, we're doing that.
Absolutely.
We can
Yeah,
connect you two together.
Yeah, 100% would be
Linda and I do
the
best.
editor-in-chief,
Connect
Sharon.
people.
Yes.
I gotta start my bake sale, cookie sale now to buy my ticket to Dubai. But yeah.
Yeah, it's not as
Bring some
expensive
fun.
as
Then we
South
will have some
Africa,
training
right?
courses as well down the line. We'll establish training courses with the universities here in Dublin. So hopefully all down the line. Yeah, we just
Oh, then
started,
we'll go to
but
Dublin. Good.
We're gonna go to Dublin. Is what
Yeah.
it sounds
Dublin's
like.
good.
Yeah.
Dublin's
Dublin's
Very
great.
well.
Patrick's
Yeah.
Day in March. We'll go. It's be good.
Thank you so much.
7
forget
days.
about us, Omar.
Time
Don't forget
and
about
for-
us.
What time
forget,
is it
don't
in
leave
what
us
time
out.
is it in Ireland?
What?
Sorry,
What time is it where you're at?
it's
It's
11
like-
p.m.
What is it?
11 p.m.
Oh my gosh. Okay.
Yeah, he's such a trooper.
I
I
know,
give
well-
him all the
well,
credit
yeah.
in the world.
I know. Well, have a good night. I'm sure you're tired.
We
No, I'm
appreciate
grand. Don't
you
worry. It's all good.
so much.
Okay.
This was great. I'm glad we connected you two.
Thank you for having me. It was a pleasure. It was a
Thank you.
pleasure. Thank
This
you.
was really fun. Thank you so
Yeah,
much.
it's always,
night.
we love having you guys. Thank you so much.
Thank you. Have a good night, everyone.
And it's all taped, so
Bye.
people
Yes.
can rewatch it.
Oh, yay.
Beautiful. Thanks.
All
All right.
Bye.
Bye.
Bye, guys.